Hello, everyone. I'm sorry I'm not there in person, but I'm here for any questions you may have. Um, what we're going to discuss now is the hormonal basis and medical oncology approaches for the treatment of neuroendocrine tumors. Now, before we go into the different type of neuroendocrine tumors and what are the different hormones that these tumors can produce, let's just do a little bit of a background and what means hormone insufficiency or deficiency or hormone excess. In our body, we have different glands, and these glands they have the capacity to produce hormones, such as the thyroid gland. The other one is pituitary gland. So the other one is pancreas as well. That they have the capacity to produce hormones, and depending on what hormones are produced, they're needed as well for the basic functions of our body. But sometimes when there is a tumor, or it may cause excess of hormones, and sometimes there are different mechanisms that they can cause hormone insufficiency. Some of them is autoimmune, or some of them is because of surgery. So it's important to recognize what is hormone insufficiency versus hormone excess. And as we can see here, hormone insufficiency or deficiency is when that specific organ that produces hormone may not be enough, and hormone excess is too much hormone, and because of that, they can produce different symptoms. So now let's discuss a little bit about what neuroendocrine tumors produce hormone excess. So as you have learned earlier, neuroendocrine tumors can be anywhere in the body, and depending on where in the body is or the organ that is affected, they can produce hormones, and these hormones can present different clinical manifestations. So we can see that there are different neuroendocrine tumors of the thyroid, the lung, the pancreas, the adrenal. But today we're mainly going to focus about the hormones that are produced by the pancreas neuroendocrine tumors, as well as the small bowel neuroendocrine tumors. But if you have any questions about any other neuroendocrine tumors and hormone excess, please reach out to me. Mary Ann has my email, so if there is any questions, please reach out to me anytime. Now, let's talk a little bit about the GI and neuroendocrine tumors, or small bowel neuroendocrine tumors. Approximately 90% of patients with carcinoid syndrome involve the liver, with primary tumors in the distal small intestine or the proximal hormones. So let's discuss a little bit how this excess of serotonin means, and let's discuss a little bit about the pathway. So as we can see here, I hope you can see my cursor, but here in the small intestines, they are what we call as small intestinal crypt, and these are responsible to in the functions of gastrointestinal regulation, as well as motility and secretion. So in this small intestine, there is very specific cells, which are the enterochromaffin cells, and these are type of endocrine cells. Now, whenever we eat something that may have high content of tryptophan, or any food that may have tryptophan, because tryptophan is considered an amino acid, then it's metabolized here into these cells, which are located in the small intestine. So that tryptophan that is acquired from diet, it is converted to serotonin due to an enzyme that is called tryptophan hydroxylase. And that's important because now there is a medication that inhibits that enzyme, and we'll discuss a little bit more about that. And then once tryptophan is then converted to serotonin, then after that is metabolized in the liver, and then appears in the urine in form of 5-HIAA, or 5-hydroxyndolacetic acid. Now, this is another representation. As I discussed earlier, tryptophan is an amino acid needed for normal growth in infants too, and for the production and maintenance of of the body's proteins, as well as muscle enzymes and other neurotransmitters. And I said earlier, it usually comes from the diet. And there is quite various food that has tryptophan. And like I said, it's an important amino acid. And we discussed that the tryptophan is converted to serotonin due to the cells that are located in the small intestine, and then is metabolized in the liver to then produce 5-HIA, and we can measure that in the urine or in the blood. As we know, there are specific symptoms of related to the serotonin excess, and we call those carcinoid syndrome, and we'll discuss a little bit more about that. But the most common symptoms that we see in a patient that have this excess serotonin is flushing, diarrhea, shortness of breath, some palpitations, wheezing, and these excess of serotonin can also cause complications as well, and we'll discuss a little bit about that. So what is the effects of elevated serotonin? It can cause carcinoid syndrome, and we'll discuss more about what that means, and as well as tumor growth. And it's been also proven that this serotonin can have tumor growth, and that's the reason why there are medicines now that help us lower this level of serotonin. As we discussed earlier, the most common symptoms of carcinoid syndrome are flushing, diarrhea, wheezing. These excess of hormones can accumulate in the heart, and that can also form scar tissues, and that's what we call carcinoma heart disease. And I'm sorry that you cannot see the representation here, but just to let you know, these are the what patients have reported as the most common symptoms, and the one that is the most reported here is flushing, and then diarrhea, as well as heart lesions as well. Whenever these excess serotonin accumulates in the heart valves, then they can cause carcinoma heart disease. But they can also cause different symptoms as well, and it's important to recognize and understand and manage these symptoms, because some of these symptoms can be quite detrimental for your day-to-day activities. Some of the questions that I have that I get from patients is that about the 5Es. What does that mean? And the idea of these 5Es is can also exacerbate some of the symptoms related to carcinoid syndrome. But that said, it doesn't happen to every patient. So what I want to say with this figure is that even though they may have certain food contents that may have more tryptophan than others, it doesn't mean that you have to stop eating those. I think you need to recognize what foods or activities may cause an exacerbation of carcinoid symptoms, but I don't want you to deprive of any of these. I think every patient is different, and every patient may have also different reactions to different aspects. But the 5Es stands for epinephrine. Eating, as we say, there is different foods that have high content of tryptophan. As here in this figure, I mentioned a few of them. But like I said earlier, it's important to know that you don't have to stop any of these food, as you just need to recognize what may exacerbate some of the symptoms. And if that's the case, sometimes to help with those symptoms, you may require a little bit of short-acting octreotide, and we're going to discuss about that, so that way you can enjoy some of these food mentioned here. Another one is emotions, another one is ethanol, and another one is exercise as well. But again, that said, that everybody's different. I have patients that run marathons too, and they're very strenuous, and it doesn't mean that may exacerbate the carcinous symptoms. But that say, if that were to happen, if somebody's a runner or wants to do a marathon, maybe we just give a little bit of short acting before that activity, so that we can help with some of the symptoms. I think it's important that you discuss with your physician, because we also don't want you to deprive the things that you do, that you enjoy, but we can manage these symptoms, and there is medicines for that. Carcinoid syndrome diarrhea occurs in 80% of patients, and is often the most debilitating component of the syndrome. Stools may vary from few to more than 30 per day, and are typically watery and non-bloody. It can sometimes be explosive and accompanied by abdominal pain. This abdominal pain sometimes can be a consequence of a mesenteric fibrosis, meaning a scar tissue around the layers of that covers intestine, and around, because some of the tumors are located in that area, and these excess of hormones can also form this scar tissue, and that can also cause pain. So I'm sure throughout the day you may hear a little bit about this, and also our STEAM panels can also discuss that more in detail if you have any questions. And the diarrhea is usually unrelated to the flushing episodes. In terms of the management of this carcinoid syndrome, there are various treatments that we can discuss. One of them is the somatostatin agonist, either lanreotide or octreotide. I'm sure you have heard throughout the day what is lanreotide, what is octreotide. There are injections. One of them is some intramuscular. The other one is given subcutaneous. There are short-acting octreotide. There is no short-acting lanreotide. I'm sure you have heard that they're equivalent as well in terms of efficacy, and we usually recommend one of the other, whatever your insurance can approve. But the function of the somatostatin agonist is two of them. One of them is to control the growth of tumors, and the other function is to control the excess, the symptoms related to hormone excess. Many of these neuroendocrine tumors, or majority of these neuroendocrine tumors, express somatostatin receptors. You also have heard from Dr. Shahand about the somatostatin receptors, and if they're positive on the Gallian scan, then as long as they are positive receptors, then you can either be eligible to get this type of therapy, or even the radioligand therapy with 177 lutetium dotatate or Lutathera. That's some of the names. But again, yes, it's important that these injections is also given as long as you have a positive Gallian or dotatate scan. And just to reemphasize that it has two functions. One is to control the growth of tumors, and the other one is to control the symptoms related to hormone excess. Most of the times, these injections are given every 28 days, but there is a short-acting octreotide that sometimes is needed and given on top of your long-acting injection. And it's important to recognize when it's needed as well, so that way you can use it and as needed. But there are other medications too that are on the pipeline that we're going to discuss a little bit. Now, I mentioned earlier that the conversion of tryptophan to serotonin requires an enzyme, and that enzyme is called tryptophan hydroxylase. My apologies. And that enzyme can be blocked by a medication. The name of the medication is called telotristat or Cermelo. I'm sure you have heard that throughout the day. So just to repeat again, tryptophan is converted to serotonin due to these enzymes that is called tryptophan hydroxylase. And then once tryptophan is converted to serotonin, then it's metabolized in the liver in form of 5-HIAA, and that's measured in the blood and in the urine. As I mentioned, the telotristat is a medication that is approved by the FDA for carcinoid syndrome diarrhea because it inhibits that specific enzyme. There has been a study also that led the approval of this medication, and is based on information that it decreased the levels of 5-HIAA, as we can see in this graph. So the negative, the numbers, is the most decrease of 5-HIAA, but it's also decreased the number of bowel movements as well. And because of that, this medication has been approved for carcinoid syndrome diarrhea, and especially when it's refractory also to the somatostatin agonist. There is an ongoing study of, and this data has been presented at one of the meetings as well, of the efficacy of paltusotine. So paltusotine is also a type of somatostatin agonist, and it has been proven that it can help also the symptoms related to carcinoid syndrome. Right now, there is a phase 3 study. The phase 2 result has been reported, and there is a benefit of this medication and in patients that has carcinoid syndrome and carcinoid syndrome diarrhea. And it's important to know about this drug because this drug has been also been used in studies for other indications as well. So let's discuss a little bit about carcinoid heart disease. So I discussed earlier that the excess of serotonin can then accumulate in the heart valve, and and this excess of hormones can cause scar tissue, and that can cause complications, and then patients can develop what we call carcinoid heart disease. So as we discussed earlier, it has, again, tryptophan converted to serotonin, and then in the small intestine, and then it's metabolized in the liver in form of IHIAA. But this excess of serotonin is coming from the metastasis as well. Liver metastasis can also travel to the right side of the heart, because that's closer to the liver. And that can affect the heart valve, can cause scar tissue, and that we call carcinoid heart disease. So now there are upcoming recommendations as well, and some recommendations on how to follow patients to prevent for patients that have excess of hormones, to prevent carcinoid heart disease. We don't have enough guidance on what the levels of serotonin of IHIAA is needed in order to then start asking for patients to have an echocardiogram. But what we know is that 24 hours urine of IHIAA, that is maybe 2 or 3 times upper limit of normals, there is a risk to develop carcinoid heart disease. So in those situations, it's recommended to have a screening echocardiogram. So you need to see a cardiologist, and the cardiologist will request an echocardiogram that can be done anywhere from 6 to 12 months, or anywhere from 1 year to 2 years, depending on in patients and how often it's needed as well. There is a blood test. It's called the pro-brain natriuretic peptide. We call it pro-BNP. This is a usually a protein that is produced by the heart. We use it a lot in patients that had heart deficiency, and it seems that maybe a correlation between the levels of BNP and the risk of developing carcinoid heart disease. And I think that's something that we need to understand more, and what needs to be done. I usually like to obtain this as a baseline, and then continue to follow up patients every time that patient has scans. And if I see a patient that have serotonin or 5-HIA levels that are elevated 2 or 3 times upper normals, I do refer the patients to the cardiologist, so that way they can have an echocardiogram. I mentioned about the lotristat. The lotristat is proven for carcinoid syndrome diarrhea and refractory to somatostatin agonists. But there is currently a study of giving the lotristat also for the prevention of carcinoid heart disease, so to minimize the symptoms of carcinoid heart disease. This is my understanding is that this study is available at MD Anderson, but that's so that the company would like to understand if I given this medication to lotristat that it was only approved for carcinoid syndrome diarrhea, could that help also for the treatment of carcinoid heart disease? So more information about this as well. So in summary of the excess of serotonin causing carcinoid syndrome, we know that that's the driver. This serotonin is the driver to cause these symptoms. Serotonin, we discussed, plays an important role to develop this excess of hormones can develop carcinoid heart disease, mesenteric fibrosis. I'm sure you have heard this throughout the day, although also pulmonary heart rate hypertension, but that's usually because of the complications of the carcinoid heart disease as well. Serotonin, we discussed, it has demonstrated effects on the tumor growth, and it's important to control the serotonin because it can also improve the quality of life as well as the prognosis in patients with carcinoid syndrome. And I would like to thank you, Dr. Monchahan, for giving me a few of these slides, and he's phenomenal. So please learn as much from him and while he's there. Now, let's discuss a little bit about pancreatic neuroendocrine tumors. Up to 30% of pancreas neuroendocrine tumors can secrete hormones, and these hormones as well can cause very specific symptoms. There are most, as I discussed earlier, most of the pancreas neuroendocrine tumors, they are non-functional, meaning they don't produce hormones. But like I say, a few of them can produce hormones, and what hormones they produce. These pancreas neuroendocrine tumors can produce excess of insulin, and because of tumor in the pancreas called insulinoma. And this excess of insulin can cause hypoglycemia. And there is another hormone produced by the pancreas. It's called gastrin. Gastrin is important to regulate the acid in the stomach. So if there is a tumor in the pancreas or small intestine that may produce a gastrin, that's called gastrinoma. And because this gastrin stimulate the acid in the stomach, so a lot of gastrin may cause a lot more acid in the stomach, and because of that, that can cause ulcers. It can also cause diarrhea. There's a name for that. It's called Zollinger-Ellison syndrome. VIPoma, that's caused by an excess of vasoactive intestinal peptide, and this vasoactive intestinal peptide is important to regulate the electrolytes and water within the body. So when there is an excess of these hormones, then you can lose a lot of electrolytes, and the diarrhea is quite profound. So we'll discuss a little bit about that. Glucagon is a hormone that also helps to regulate the glucose in your body. And if there is a neuroendocrine tumor of the pancreas that produces glucagon, that's called glucagonoma. So having excess of these hormones can cause diabetes, can also cause a very specific rash, can also cause muscle mass, because glucagon also helps in metabolize amino acids in the body. So that you can also lose a lot of muscle mass as well. Very, very rare is a tumor called somatostatinoma. So it's an excess of somatostatin, and somatostatin is responsible for metabolize the bile acids in the body, and if we have an excess of this, it can form bile stones. It can also increase the fat in the stools that can cause a malabsorptive diarrhea. It can also cause diabetes, because somatostatin also inhibit the insulin production in the body, and if that's the case, then the patients can develop diabetes. But again, these are very, very rare. And if the question is like, oh, I have a pancreas neuroendocrine tumor, so I have any excess of hormones. So you usually recognize because of the symptoms. The symptoms are very, very evident. If you don't have any of these symptoms, it's likely that your pancreas neuroendocrine tumors may not produce hormones. But there's certain case scenarios that some of these pancreas neuroendocrine tumors very rarely were known as being non-functional, but then they sometimes, can produce some excess of hormones. But that said, it rarely happens. I'm happy to clarify if you have any doubt on this statement. So insulinoma, what are the symptoms of insulinoma, or how insulinoma may present in a patient that has a pancreas neuroendocrine tumors producing excess of insulin? Usually how it presents is that patients may have symptoms of hypoglycemia. Which one are those? As we can see, it can be a variety of symptoms, such as being shaky, increase in the heart rate, being sweaty, dizzy, anxious, sometimes headache. They can be very irritable, and then that's because of the glucose, and that can be present when the glucose goes below 50, and is usually relieved, those symptoms, by eating something that is very heavy in sugars, like ice cream or orange juice, like it's very, very high in sugar. That's released. Those symptoms are relieved by those type of food. Now, what is the treatment of insulinoma? Usually surgery. So we have patients that usually have localized insulinoma, and that's the most common presentation of insulinoma, because, like I say, whenever it's an excess of insulin, that's going to lower your blood glucose, and you're going to have symptoms. So often, or most of the times, are diagnosed localized, which is good because you can resect it, and once the tumor is resected, so the symptoms improve. But in certain situations, sometimes the surgeons are unable to localize insulinoma because it may be very, very small, or sometimes in some scenarios, these tumors can also metastasize and can go to other places. And if they go to other places in the liver, then can produce insulin. And that's when we need to make sure that we have all the tools in order to control the excess of symptoms, excess of hormones that cause the symptoms. As I say, surgery is the surgical the approach for these tumors. But if we are unable to do surgery, it's important that the extra measurements needs to be done, frequent small meals with rich in complex carbohydrates, as there is a medication called dioxazide that basically blocks the insulin excretion from the cells, and also somatostatin agonists. I discussed earlier these injections, these somatostatin agonists, lanreotide, octreotide, do functions, control the symptoms related to hormone excess, as well as control the tumor growth. There are other things that can be done as well for the management of these tumors. So we discussed about somatostatin agonist surgery, the bulking surgery. I can also help. There has a lot of information that in subset of patients that have a lot of tumors in the liver is evaluated by surgeon, and they can do what we call a cytoreductive surgery. That said, that's always that's one of the reasons that we advise that patients can see a neuroendocrine tumor expert, because usually in those centers they have all the players necessary to make recommendations of what are the best treatment options between surgery or interventional radiologies and nuclear medicine physicians, medical oncologists, and endocrinologists. So all of them are important to have a discussions to understand what makes the most sense. Some patients may be eligible for surgery, some other patients may not, and it's important to discuss all the options with your physician. And of course, the systemic therapies that maybe Dr. Shahan will discuss today. Gastrinomas. We discussed that gastrinomas is a tumor in the pancreas, neuroendocrine tumors that cause excess of acid in the stomach. And it can be also in the pancreas, but it can also be in the small intestine too. This excess of gastrin cause, as I say, it stimulate some of the cells that are in the stomach, and these cells are responsible to produce increased acid in the stomach. Because of that, these patients may cause these excess hormones, produces ulcer or peptic ulcers, but sometimes they can cause more symptoms such as diarrhea, heartburn, because of what we have seen in these patients, as well as weight loss. Very important that if a patient is diagnosed with a gastrinoma, very important that these patients receive a medication called the proton pump inhibitors, because that inhibits that specific acid produced by the cells in the stomach. And one of them is omeprazole, pantoprazole, and the other drug is called pantoprazole. I'm sure you're familiar with some of these drugs, but the difference between somebody that have a gastrinoma versus somebody that has only GERD, what we call gastrointestinal reflux disease, the difference is that in patients with gastrinoma, they need to have high dose of these proton pump inhibitors, usually twice a day. If the tumor is recognized and is localized, surgery is the option for these patients, but that same patients, the surgery is not an option. So there are different treatments. The somatostatin agonists, octreotide, lanreotide. As I said, this can also help the symptoms related to hormone excess. Surgery, as we discussed similarly with insulinoma, important to also discuss your case with a surgeon to determine whether your tumors can be resected, and other systemic therapies, as you heard throughout the day. So we discussed about VIPoma. So VIP is for vasoactive intestinal polypeptide, and the oma because it's like a tumor, right? VIPoma. And as I say earlier, this hormone is responsible to regulate the electrolytes in your body, and these patients may present with watery diarrhea, but usually it's a large volume, anywhere from 700 to 3,000 cc's per day. Because of these severe diarrheas and also because of the function of this hormone in the body, you also lose a lot of electrolytes. So patients may have very low potassium, very low chloride. These patients may present with abdominal pain. So it's important to recognize it, because we need to replete those electrolytes. All these electrolytes are needed for the body and for functions on the body. If you have a very, very, very low potassium, that can also affect the heart. So it's important that if we recognize, fortunately, these are very, very rare, right? But if it happens, so we need to make sure that we replete the fluids and electrolytes as well. We discuss about octreotide and lanreotide, as gained, emphasizing that besides the tumor control, it can help also for the symptoms related to hormone excess. Some patients, when they don't respond to these therapies, then we need to add steroids, like prednisone. Sometimes that can help, and loperamide sometimes can help a little bit with the diarrhea. So we need to take any measurement in order to control the diarrhea, because the diarrhea can be quite profound, and volume as well. It's very significant because they can, as I say, they lose a lot of electrolytes. In patients that is unable to have surgery, then besides the somatostatin agonist, they can also consider surgery or the systemic therapies, as has been discussed throughout the day. Glucagonoma, these are very, very rare as well. So we're talking about the most rare of the symptoms. The glucagon is responsible for inhibiting excess of glucagon can inhibit the insulin secretion. It can also affect amino acids, essential amino acids in the body as well. These patients may present with weight loss. They have a very specific rash. This is kind of how it looks like, as we can see in this picture. This rash is called necrolytic migratory erythema. So it's a very long name, but it's a very specific rash that is related to glucagonoma. Other symptoms that these patients may have, chronic diarrhea. Sometimes they can also cause clots as well in the body, very rarely, but it can happen. And other symptoms as well can happen with this excess of glucagon. So important to manage diabetes in these patients when there is excess of glucagon. It's important to manage the diabetes. As I say, glucagon inhibits the insulin production. If you don't have enough insulin, it can lower your glucose. Your glucose goes high, and that can cause diabetes. Important to give nutritional support. Important to give infusions of amino acids and fatty acids as well, because this glucagon also metabolize and interfere with some of these amino acids absorption, and as well as octreotide, lanreotide. Those are the general measurements. If the patient has advanced disease, as we discussed earlier, there are other treatments that is indicated, including surgery, liver-directed therapies. I'm sure you have heard about that, or what are the liver-directed therapies, what are the type of liver-directed therapies and what can do, and systemic therapies as well. Now, somatostatinomas, this is also very rare. Somatostatin hormone is responsible as well of insulin metabolism. So you have a lot of somatostatin that also inhibit the insulin secretion. It can also, somatostatin is also responsible for metabolism of the bile acids, so it can also cause gallstones, and it can cause diarrhea as well and fat in the stools. Surgery is the treatment of choice if it's localized, but if the patient cannot have surgery or is in advanced stages, there are different therapies that can be recommended, but very important to discuss with your physician or your treating physician. So before going to thoracic neuroendocrine tumors, so as we can see, we discuss the neuroendocrine tumors of the pancreas that may produce excess of hormones. Fortunately, it's not like everyone can produce hormones. Majority do not produce hormones, but if they produce hormones, then there are extra measurements that we need to take besides the other treatments that you have heard throughout the day. So now let's discuss about thoracic neuroendocrine tumors. Thoracic neuroendocrine tumors, so it's neuroendocrine tumors that can be localized in the lungs as well as the thymus. These tumors can also secrete excess of hormones, can secrete serotonin too, and this serotonin can also cause carcinoid syndrome. But also these neuroendocrine tumors can also produce another hormone, an excess of hormone called ACTH. ACTH stands for adrenocorticotropic hormone. So this ACTH is responsible to stimulate the cells in the adrenal gland to produce cortisol. So cortisol is an important hormone because it's a stress hormone. It helps you with the fight and flight response. But if you have excess of cortisol, it can have a series of symptoms, and that's usually because ACTH sends a signal to the adrenal gland to produce a lot of cortisol, and that can also come from the lung neuroendocrine tumors. And this can, in this presentation or clinical presentation, is called Cushing's syndrome. Cushing's syndrome of excess cortisol also have a series of symptoms too. It can cause high blood glucose. It can also cause fluid retention. It can also cause red face. It can also cause accumulation of fat in certain part of the body, like in the area or the back of the neck. We call that buffalo hump. So they can also affect the bone density, so it can cause osteoporosis. It can also cause decreased healing. So this excess of hormone can certainly cause a lot of symptoms, and it's important to inhibit these hormones. There is medical therapy that inhibit these excess of hormones in patients that had neuroendocrine tumors that they're slow growing, that we know that some of these patients may not be eligible to resect all those tumors or surgery. Sometimes it's advisable to remove the adrenal glands, because if you remove the stimulus, then you don't produce excesses of cortisol. So it's something to discuss with your treating physicians. There are other medicines that is given to block the excess of cortisols. Some, as we can see, some of these ketoconazole, methadone, mitotane. But like I say, sometimes in patients, we know that these neuroendocrine tumors are slow growing. If that's the case, so we recommend to removing the adrenal, so that way this ACTH that is produced by the neuroendocrine tumors doesn't go to the adrenal gland and stimulates cortisol. So by removing the adrenal, then there is no stimulus. Crinetics has a medication is currently on clinical studies, and this is a drug that inhibits the ACTH secretion. And here at the NIH, Dr. Niemann is the person, she's an endocrinologist, and she has that study open in patients that have Cushing's syndrome because of this excess of ACTH. So throughout the day, you're going to discuss the different therapies for neuroendocrine tumors. A lot of these therapies is not only help to control the symptoms related to hormone excess, but also to control tumor growth or even shrink tumors. And these are the different therapies. And it's important also to know that in terms of the management of neuroendocrine tumors, it's not like one size fits all. So the recommendations are very specific from patient to patient. And that's the reason why we discussed that neuroendocrine tumors patient needs to be seen by someone who knows neuroendocrine tumors, because we have a series of treatments, but we don't have any data that tell us this is what you need to do as a first line, as a second line, as a third line. Like I say, usually the recommendations is very specific from patient to patient, and understanding as well the characteristics of the neuroendocrine tumor, whether it's functional, meaning producing hormone or no hormone, whether they express the receptors, the somatostatin receptor, whether they're slow growing or rapidly growing. Also understand how much tumor it is when we look at the scans, whether it's large volume, low volume, whether it's only in the liver. So we can see there's different measurements or different treatments that can be given. But again, the treatment is personalized from patient to patient. So this is a summary in terms of the symptom management of hormone excess. So these neuroendocrine tumors can produce excess of hormones. If it's in the small bowel, can produce excess of serotonin. If it's in the pancreas, depending on what cell in the pancreas is affected, they can produce excess of insulin or gastrin or glucagon or somatostatin or VIPomas. And then if it's in the lungs, they can produce this hormone that stimulates the cortisol and cause Cushing's syndrome. So, but depending on what is the clinical characteristics, there are extra measurements that we need to also provide the patient in order to control the hormone excess. Whenever the trainees comes to me and present a case with neuroendocrine tumors, I usually ask, especially the ones that produce hormones, what we need to do in order to control the symptoms related to hormone excess, and what we need to do in order to control the tumor growth, because sometimes they may not correlate. So it's important to know that these tumors can produce excess of hormones, and depending on what hormones they produce, other measurements needs to be indicated. Now, just briefly, let's talk about hormone insufficiency. We talk about hormone excess, but let's talk about hormone insufficiency, because I think it's important to know that some of these medications and that we provide, they can also cause hormone insufficiency as well. And that's why in a patient with neuroendocrine tumors, I always advise if it's possible, to have an endocrinologist that can manage some of these symptoms. So somatostatin agonists, such as sandostatin or lanreotide, as we discussed earlier, these medications can inhibit these somatostatin agonists, either sandostatin or lanreotide, can inhibit the secretion of insulin. So in the pancreas, we have cells, it's called the beta cells, and these cells are responsible for the production of insulin. And these medications sometimes can inhibit that secretion of insulin. And if that's the case, if you don't have enough insulin, then it's not enough to lower the glucose level. So whenever we eat, so our glucose goes high, and in that situation, that's when the pancreas secretes this insulin in order to lower the glucose, but if you don't have enough, so the glucose will be persistently high. So high glucose is observed in about 27% of patients that are using these medications, other as sandostatin or lanreotide. As I say, it's a very good medication also for patients like insulinoma that produce excess of insulin. But in rare cases, it can also cause hypoglycemia, so low blood glucose, in the sense that they may not do anything to the beta cells in order to inhibit the insulin secretion. To the contrary, you can see that this insulin secretion can be quite active and very rarely can cause hypoglycemia. So it's important to recognize that as well. Personally, I have seen it a little bit more with sandostatin or octreotide than with lanreotide. I have seen more high blood glucose with the lanreotide, but this is important to recognize that very, very rarely happen, but it can. So most of the time it produces excess of glucose or hyperglycemia. Another medication is called everolimus. And again, the reason why it's called hormone deficiency is because you don't have enough insulin to do the action that is indicated to lower the blood glucose. Everolimus is a drug that is indicated for patients with neuroendocrine tumors, as you have heard throughout the day. But everolimus has, as a side effect, it can also inhibit the insulin secretion from the beta cells. And again, if you don't have enough insulin, so then the blood glucose doesn't go to normal levels, persistently high. So that's why everolimus is also a good drug for patients with insulinoma. Makes sense, right? Because insulinoma is excess of insulin, so you give everolimus, that can also block the insulin secretion. So everolimus can be a good drug for patients with insulinoma. Usually it's given earlier as well. But it's also side effect. It can also cause, in terms of hormone deficiency, doesn't produce enough insulin, and that can cause high levels of glucose or hyperglycemia, and that's reported anywhere from 12 to 50% of cases. So it's important to recognize as well that this can increase the blood glucose. So whenever you see your doctor, you also ask for about the glucose levels, especially if you're on everolimus or even as well on the somatostatin agonist. So, and that's kind of like what in cases is persistently elevated, then it can cause what we call type 2 diabetes. So type 2 diabetes is when there is insulin, but there may be not enough insulin, or the insulin is not doing the job that it's supposed to do. So there is type 1 diabetes when there is no insulin and we need to give insulin. But in type 2, there is insulin, but it's not doing the job that it's supposed to be doing. And as I say, there are certain medications that can cause that. So these are the different signs and symptoms related to type 2 diabetes. If the blood glucose is persistently elevated, then it can then develop this type 2 diabetes. It's important that if glucose has been persistently elevated, ask your doctor to check a hemoglobin A1C, which it tells me how your glucose are within a 3-month period. And depending on the levels, that can also be diagnostic for this. But these are the different signs and symptoms related to diabetes, excessive thirst, weight loss, frequent urination, fatigue, blurry vision. So those are some of the symptoms as well. And it's important to recognize, and there are treatments for diabetes. There are lifestyle modifications as well that needs to be done. Usually that's the first line of treatment that we recommend when a patient is already diagnosed with diabetes. And there are medications as well that is recommended, and always check your glucose when that happens. And the reason why, like I said earlier, is within the hormone insufficiency, because it's not enough insulin, or the insulin is not working properly to lower the blood glucose, causing type 2 diabetes. Also, there are medications, like you have heard today, medications such as sunitinib, cabozantinib, which was recently approved by the FDA for the treatment of neuroendocrine tumors. These medications are within the family of the tyrosine kinase inhibitors. These medications, what they do is block the blood vessel supply going into the tumor. But in depending on what tyrosine kinase is, some of them have high risk to develop hypothyroidism compared to others. So hypothyroidism is when there is not enough thyroid hormone. So again, hormone insufficiency causing this medication causing hypothyroidism and not producing enough thyroid hormone. And we can see here that medications of sunitinib or cabozantinib has been associated with causing hypothyroidism, and more often than others, tyrosine kinase inhibitors. So patients that need to be placed on this medication, it's important that they have a baseline thyroid function test and then check regularly, and maybe every 12 weeks or whenever they have scans, just to check. There are very specific symptoms of low thyroid hormone, and we're going to discuss about these symptoms as well. Somatostatin agonists such as lanreotide, octreotide, they can also cause thyroid dysfunction. It's less than 1%, but rarely has been seen. And the reason why I mention this, because these are medications that we often provide for the treatment of neuroendocrine tumors. These medications are efficacious. Cabozantinib, I'm sure you have heard about cabozantinib. It's very good that it's approved by the FDA, because we have another option as well for neuroendocrine tumors, and they're very good for the treatment of neuroendocrine tumors, but sometimes it can cause some side effects, and it's just recognize the symptoms so that way we can treat based on the symptoms. These are the different symptoms related to not having enough thyroid hormones, so increased weight, intolerance to cold, depression, sometimes hair low, constipation, menstrual irregularities, fatigue, joint pain. So there is different symptoms related to low blood glucose, and if that happens, we recognize it and we give what is needed. And it's very easily to replete thyroid hormone deficiency with a medication called levothyroxine. In summary, 10 to 30% of pancreas neuroendocrine tumors secretes hormones, resulting in clinical syndromes. Mid-gut neuroendocrine tumors may develop carcinoid syndrome. Bronchial or thymic neuroendocrine tumors may develop Cushing's syndromes due to the excess of this hormone that stimulates the cortisol levels. So additional measurement is needed in order to control the excess of hormones, as we discussed. Biochemical assessment in relationship to the clinical presentation, because if the question is like, do I need to check all these hormones? Not necessarily. Only if there are symptoms. And like I said, the symptoms are very specific based on what hormones the tumor is producing, and they're very evident. So based on symptoms, that's when we then check for these hormones. But like I said, in terms of pancreas neuroendocrine tumors, most of them are not functional, meaning not producing hormone. But as I discussed earlier, if there is a neuroendocrine tumor that produces any of these hormones, so any additional measurements are needed in order to control this excess of hormones. Somatostatin agonists, such as lanreotide, sandostatin, and everolimus, can cause hyperglycemia, sometimes depending on how persistently the blood glucose is, it can lead to diabetes. So something to keep in mind and checking your blood glucose. We discussed about tyrosine kinase, such as sunitinib, cabozantinib, that has been used for the management of neuroendocrine tumors, can cause thyroid dysfunction. So it's important to obtain a baseline thyroid function test and then check regularly. And if it's happen, we repeat it. These are some of the things that management of hypothyroidism, management of diabetes with the right medication is we can control it. And I don't want you to feel concerned about any of that, because these are very easily things that we can control, and it's important to see an endocrinologist for that. In terms of advanced metastatic disease in patients that we are unable to do surgery and have these excess hormones, there are different treatments that can help to control the tumor growth, but at the same time, if the tumor shrink or have tumor control, that can also help to some of the symptoms related to hormone excess. And we discussed about somatostatin agonists such as lanreotide, octreotide. Surgery in a subset of patients, surgery may be beneficial. Liver-directed therapies with ablation, embolization, PRRT with Lutathera. You have heard a lot about this today from Dr. Shahant. Chemotherapy as well, targeted therapy, everolimus, sunitinib, or cabozantinib. And the reason why it's called targeted therapy is because it targets specific protein or in the surface of the cancer cells, and they're like everolimus, sunitinib, or cabozantinib are some of the medications, and those are the treatments. But you please take advantage of the speakers today. They are there to help you. NCAN is a wonderful organization. It has a lot of patient support and education. And you have the line of the speakers today is fantastic. And please ask questions. We're here to help you. I'm sorry I'm not there, but Dr. Shahant is amazing as well. So, and everyone there is amazing. But if you have any questions, please reach out to me. Marianne has my email. So just send me an email. I will reply to you. Okay. And with that, I thank you for your attention. Enjoy the rest of the meeting.